My name is Nabil Risk. I'm a thoracic surgeon. I do lung cancer surgery and esophageal surgery and any other cancer in the chest. Most patients with a presumed diagnosis of lung cancer are very much afraid because the data on lung cancer as far as the prognosis is not very good. And so one of my goals in seeing those patients, regardless of their stage, is to tell them that there is a treatment for any stage of their lung cancer. Some of them is going to be surgery, some of them is going to be non-surgical treatments, but at the end there will be a treatment.
So this is a 66-year-old, 1 pack per day cigarette smoker. He underwent a CT of the chest demonstrating a nodule in the left lung apex.
The lung cancer care at the John Theurer Cancer Center is kind of a one-stop shop, and it's kind of underestimated what it goes behind the scenes. To be able to take care of one patient, there is a huge team behind the scenes.
Corresponding CT, that's about 8 millimeters, maybe a little bit more.
John Theurer Cancer Center is quite a unique place. It has many disease-specific divisions. Our working relationship is very close, and being in the same building is really to the benefit of the patient.
Do you have any comments about management of this case?
The idea with the tumor board is to include everyone who could potentially play a role in taking care of that patient. So in that particular tumor board, there are oncologists, radiation oncologists, pathologists, radiologists, pulmonologists, and surgeons, all of whom in some way or another will play a role in the care of a patient with lung cancer.
Because this was new 3 months ago, I may just repeat it in 3 months. You could also easily take it out, but I don't think it needs to come out.
Okay.
But at the same time, we see the big nodule. You see it radiologically. If you leave it there for long, it can grow. So,
the thoracic division is also embarking on a screening program for high-risk patients. And the idea is to pick up early lung cancers before they've had a chance to grow and spread. If they're surgical candidates, they will go and have their surgery. If they're not surgical candidates, those patients that are medically inoperable also have an option now. It will be the body radiosurgery.
A lot of the innovation in lung cancer now is happening on the medical oncology side. The development of immunotherapy, targeted treatments, all those treatments, a lot of them have to start somewhere in a clinical trial. And so the Cancer Center is very central to that because they have access to those drugs.
9/16/2015 patient actually very well. Continue on our clinical trial with the C. We have or provide access to the patients to really the new therapeutic interventions that otherwise may be between 5 years to 10 years before get approved to be commercially available.
Hello.
Yeah. How you doing? How's things going? How are you feeling? One example that we have is a patient, Ms. Duda. Ms. Duda came with a diagnosis of lung cancer, and we spent a good amount of time specifically going through standard therapy options, and secondly, going through clinical trials possibilities. At any given time, we have probably between 2 to 4 studies that any given patient could qualify for it. So Ms. Duda and I decided to participate in one of those studies, and she has received already 2 cycles of standard chemotherapy with an experimental immunocheckpoint inhibitor. When we met initially, the tumor size was 9.7 on the right side. Now we are going down to 2.7 centimeters in the tumor size. So that is very
amazing.
good news.
That's amazing.
So Ms. Duda has completed 2 cycles, has had an excellent response. Her symptoms has improved. And it's how I describe it best. You can see her walking on the streets and you will never guess that she's going through treatment.
Okay, Doc.
Anything else that I can do?
No,
With
that's
the
it.
advances in oncology, on target therapy, gene sequencing and immuno-oncology, there is a message of hope, and that's how we deal with it.